Good afternoon and welcome to the Beyond the Blueprint webinar series. This series empowers health IT professionals with the latest insights, strategies, and design principles required to seamlessly integrate digital tools within their projects. Whether you're embarking on a hospital remodel, constructing a brand new facility, or undertaking a targeted renovation, technology and innovative design are playing an increasing crucial role in shaping the future of healthcare delivery. In this series, we explore how to integrate leading-edge technologies and design processes to enhance patient care, optimize operational efficiency, and to drive a positive and compelling ROI. My name is Greg Malkery. I'm the Managing Director at Spyglass Consulting. I'm also the host for this series. Joining me is my co-host, Keith Washington, a renowned serial entrepreneur and respected board member at Companions in Courage. Keith, do you have any opening remarks?
Sure. Thanks, Greg. Just to talk about some of our mission at Beyond the Blueprint. So we think that the design process is about managing complexity. We love to talk to thought leaders who are dealing with complex topics and how they're able to focus on their mission and how they might be flexible with their plans, how they're communicating with their teams. So looking forward to today and this topic and excited to keep this conversation going.
Great. Thanks, Keith. Well, I'm also pleased to introduce our guest speaker, Dr. John Lee. Dr. Lee is a former Chief Medical Informatics Officer at Allegheny Health. He's also a distinguished expert in healthcare informatics and data governance. John, welcome to our webinar. Would you like to introduce yourself?
Thanks for having me. Pleasure to be here with you and really excited to share some of my thoughts on how we can actually improve healthcare using data and information flows.
Great. Thanks, John. Now, before we dive into our discussion, I want to express my gratitude to our valued sponsors, Storage Systems and Simplify Medical. Today, we're fortunate to have Lars Anderson with us from Storage Systems. Lars, can you please share a brief welcome?
This is Lars Anderson with Storage Systems Unlimited. We're a distributor of a number of different storage items, including telehealth carts, partner with our good friends over at Simplify. So looking forward to a nice education here on how things are developing and where we're headed.
Now, during today's webinar, John will show how to enhance data utility through data governance and innovative analytics. He'll provide effective strategies to enhance patient care and drive operational efficiencies across a health system. And he'll discuss how healthcare organizations can turn their EHR data into a strategic asset essential for achieving healthcare excellence. With that, why don't we kick start with the topic of data governance. John, considering the importance of data governance, how can healthcare organizations ensure their data is accurate, usable, and secure to support advanced analytics and AI applications?
Well, it's clear to me that the issue of data quality and data governance is one of the big sticking points and impediments to us actually accomplishing some of the things that we want to do with healthcare writ large and specifically healthcare IT. It's easy enough to kind of focus in on just the data quality issue, but you also need to address some of the surrounding issues of usability, things like interoperability and incentives, because all of those sorts of things affect really kind of each other. It's kind of an intertwined, highly dependent matrix sort of interplay between all these sorts of factors. If you create a digital system and let's say you focus just on the governance and data quality, but you don't focus in on, say, usability, you end up with situations where the end users will just do whatever they can to get past a certain operational or workflow roadblock, and then you end up with really, really bad data. So, in a situation like that, the data ends up being a representation of the escape efforts by the end users and not really the ground truth of what is actually going on with that particular patient or that particular workflow.
John, how do user-friendly strategies improve the effectiveness of data governance systems?
Well, I can talk kind of about what the negative impacts are on some of the very common and I think recognizable sorts of efforts that a lot of organizations have made in the past. As an ED physician, I recall an effort where we wanted to have all the docs record a risk score. And the initial effort directed the docs to go to another resource, actually a separate web page, do a calculation, take that end result, and then manually transcribe that into the EMR. And number one, that manual transcription was actually free text, so it wasn't really readily accessible for other downstream decision support and analytics. And then the entire process of actually doing that calculation was error prone. So even if you could extract the data, there was a lot of data quality issues and unreliability of the scores and so that became problematic. So what we did was we actually embedded the entire risk scoring tool within the workflows of the EMR and pre-populate a lot of the fields based on data that was in the system. It became easier for the end user, and also the data output was then discrete and a lot more reliably accurate. So it was a win-win. It was easier to use, and you got better data. Another example, I remember we were involved in a sepsis project, and the organization had sepsis navigators running around with clipboards and paper forms where they were recording all the different various pieces of what happened with the sepsis patient. And they ended up submitting those forms, and then they were then curated and re-entered manually into a digital system downstream. Number one, again, it was error prone because it was very manual. And number two, the data that was collected wasn't folded into the actual underlying data stream of operational workflows, and therefore that very valuable data was then lost to all the other downstream secondary uses of those data, and it was a lost opportunity.
Wow, good insight and good examples. I didn't realize the significance of that. But how does data governance manage these complexities, especially in clinical contexts with varying conditions?
Well, so one of the things that people may not realize is that when you collect data in a healthcare system, you can collect very granular bits of data, and those granular bits of data mean something only in certain contexts. So, for instance, if a patient has a low hemoglobin, they're anemic, and let's say the hemoglobin is 10, which is a low level. But if the patient is a renal failure patient, adding that extra bit of other granular raw data into that other piece of data, the hemoglobin of 10, the patient is anemic, adds more information and meaning to and context to that data. So, and then on top of that, what if, in addition to the patient having a diagnosis of renal failure, that patient's hemoglobin was 13 several months ago? That is actually significant in that now you've created information that the patient has had a significant drop in their hemoglobin, and you would do something different based on that sort of information. So, there's any number of these sorts of examples where you have raw data that then you process and turn into other kind of higher levels of data or information. And that processing and that definitional process is what's important. And so that people in different parts of the organization or people who are different consumers of data have the same understanding of what that piece of data and information mean, so that then they can make the same decisions based on the same bits of data. So If you have a length of stay, what does that mean to different stakeholders in the organization? Does it start from when the patient hits the ED, or does it start from when the patient leaves the ED and goes to the floor? If the patient has surgery, does the length of stay start from when the patient comes in for an elective surgery, or when the patient leaves the OR and hits the floor bed? So these are all different nuances that people have to hash out and define, so that if I say length of stay, that means the same thing as what you mean for length of stay. And these sorts of minutia in terms of these data definitions seem like they're really, really small and nitpicky, but they're really, really important, because people often make assumptions based on what they know, but their assumption may be different than the understanding of somebody else.
Great. Well, thanks, John. Let's pivot a little bit. Let's talk about transforming data into insights. How does advanced analytics, AI, and machine learning transform EHR data into actionable insights for personalized care and to help improve outcomes?
So one of the things that is kind of an annoyance of mine is how there has been kind of this hype understandably about artificial intelligence and how it could potentially help transform this information deluge that is negatively impacting how we deliver care in healthcare. And so if you think about it, artificial intelligence is just the natural continuation of all these other data products that we have available to us, starting from even simple descriptive analytics. But now you're going from descriptive analytics, where you may have maybe half a dozen to a dozen columns on a dashboard, and you make a decision based off that. Artificial intelligence is basically the same thing, just orders and orders of magnitude larger. So a typical traditional descriptive analytic tool may have half a dozen columns, whereas ChatGPT or GPT-4 has trillions of different parameters and essentially columns that they intermingle and allow to, in that intermingling of those different data features and columns, comes up with different insights. So it is, artificial intelligence is really just the same thing as what we did before, just a lot more complex with a lot more data features and parameters. And it's in this intermingling of columns, features, whatever you want to call them, that you come up with different insights.
Well, this kind of reminds me of some previous conversations we've had offline. Maybe you can elaborate a little bit and explain how AI can streamline these processes and help overcome these integration challenges. There seems to be a lot of promise here.
Yeah, I think the big problem that we have actually in healthcare is that we are overwhelmed with data and information. If we're trying to make decisions, and the human brain typically, to make a decision, can only consume like maybe about half dozen different data points. But if you're inundated with dozens, hundreds, thousands, actually maybe even millions of different data points that you have to pay attention to, you're going to miss some. And that is actually the essence of the problem that we're trying to solve. If you can consume stuff by just having direct exposure to something, but that is not very scalable. If you're a manager and you walk around and you talk to individuals and say, hey, what is the number one thing that is impeding the flow of the patient through the hospital? You can get input from a half dozen different nurses who may give you their truth, but their truth may not be the ground truth. And then on top of that, you're limited in terms of the sampling that you have. So what you need to do is you need to use some of these modern data science tools to get to, hopefully get to the ground truth of what can actually solve your problems.
Wow, this sounds really complicated. So how do you bring this all together? Because I know a lot of informatics folks around the country are actually trying to address this issue right now. Any pearls of wisdom or best practices?
So if you look at all the hype, a lot of the hype is based on the tools. Whether you want to use an LLM or some sort of NLP engine or a neural network, but and those are all great, and I think those are transforming a lot of the things that we want to do and transforming how we think about how to approach these problems. But if you focus just on those analytic tools, on this new age of 21st century data science, you still have to pay attention to some of the other things, like we mentioned before, usability. If you have a really unwieldy system for the end users to use and they produce crappy data, they're going to produce, that crappy data is going to produce an algorithm, a really fancy tool that will produce an insight that is completely unreliable. So, you may think about this as kind of almost a systematic way to actually produce LLM hallucinations. If your data is inaccurate, then you're going to produce inaccurate output, and you're going to be given insights that are that will not actually improve care or reduce cost or improve access. So you have to create usable workflows. You have to create good data. You then have to process it using old-fashioned descriptive analytic tools, or on the other extreme, really new advanced artificial intelligence tools. You have to come up with the right insights, and then you have to take those insights and you actually have to embed them into workflows in a seamless fashion, so that it all becomes kind of this virtuous cycle. So then you have the workflows that are embedded, and they produce more data, and that data then goes around and it keeps going around in a virtuous cycle. Whereas what I find is happening now is any given project will focus in on one part of that cycle. I think a lot of the hype is going into the processing and the artificial intelligence and the data science, but then the other parts of that virtuous cycle end up getting short shrift.
This is interesting, though. I love the idea in theory, but what about in practice? Are our clinicians ready to actually change clinical practice to adopt these technologies and tools? Are they asking for it? Or they don't really know they need it at this point?
Well, I think clinicians are ready, but if you ask them how it has actually affected them thus far, it's been very minimally. And I think it's because the implementation has often been, again, focused in on one part of that cycle, i.e. like the data science. So for instance, I remember seeing a demonstration of a product that had really good data science behind it, but the way that it was implemented, it was in an ICU. These, basically said, these are the sick patients. These are the things that you need to do for these sick patients. These are the top things that you need to address. But it displayed it on a big monitor in the ICU, and then you had to transcribe that and say, okay, this patient in bed 3 needs these 3 tests done. Now I got to type those in. And that's a very clunky workflow. Another example, I know of a very well-known population health tool that actually got removed from a large academic system because they came up with great population health insights. These are the 5 patients that you need to reach out today, and these are the 4 things that you need to do for those patients. But it wasn't integrated into the workflow, so you basically have a printout list of things of the patients that you needed to address, the things you needed to do, and then you need to walk over to your EMR and punch it into the system. That's where things fail, and there isn't enough attention on creating that integrated workflow, at least in my opinion, to positively make the impacts that we need to make.
So it sounds like the operational challenges are fairly complex. Any best practice and what we can do early on as we're still vetting out the tools and the accuracy of the data, and how this goes against certain guidelines for clinical practice, whether you're a physician or a nurse?
Yeah, think about those 4 elements: usability, data quality and governance.
Well, let's say, can you expand a little bit on how the improvements in EHR design could enhance data governance?
Yeah, I'm sorry, I muted myself because there was a loud train going on in the background.
Did you want to backtrack?
Yeah, let's backtrack a little
I think
bit.
we're talking about the issues of usability and actually putting it into clinical practice.
Yeah, I think you have to have more focus on the holistic cycle, not just on the shiny object data science tool. Create usable workflows, seamless to the end user. Create good data as a result of that. Use those good data, put it in, process it, and come up with good insights, and fold those back into very usable, seamless workflows. And if you think about it, there's the best technology out there are technology that you don't know exists. So, perfect example that's pretty ubiquitous is our keyboardless cell phones. You can type madly and crazy fast, and if you actually record what keys you're typing on, you're wildly inaccurate. But behind your activities is data science that shows that if you type a T and an H and then a W, you probably mean a T, H, and E, because the E is right next to the W and you just probably mistyped that. So expand that out to, and people don't necessarily know that that's going on behind the scenes. So if you have technology that is so good and so usable that you don't even know that it's there, that's the ultimate goal of where we want to be.
So John, but what about what you're talking about in terms of all the benefits? I guess tell us about you mentioned earlier about aligned incentives, getting the team to be part of this. It sounds like you've had some success from a leadership point of view. I guess where are you in that journey, and I guess how do you build on that? So let's say all the stakeholders feel like, no, the benefits are worth it. It's working. We need to keep going in this direction. I guess how do you feel about that from a leadership organizational point of view?
So what I have encountered in speaking to multiple organizations and in my own personal experience is that a lot of what I'm talking about is really the core of what is clinical informatics. And there is a high level of variability in how organizations use clinical informatics. And IT writ large, I think a lot of organizations view as just a commodity. It's like electricity. Novant, for example, they have outsourced their entire IT team, which I think is a mistake, because if you view it just as a commodity, as widgets that you just have to put into play, just like plugging your electrical device into the outlet, I think outsourcing it is probably a reasonable thing to do. But information delivery and the nuances of data creation, data governance, those are so intertwined with how a good organization should work that you really shouldn't outsource that. So it's kind of a long-winded answer for saying that you should view information technology and informatics as a strategic asset and not just as a cost center or a commoditized tool that just happens. it won't happen because there's a lot of knowledge work that has to go on behind the scenes to make it work. And I think a lot of organizations view it as something that is just like an electrical device that you plug into the wall.
Okay, understood. Yeah, let me push back on that a little bit because I think any business kind of faces that challenge, like where you are looking to your data for your business or your operation or your clinical workflows as a strategic asset. Let's say versus IT, which is, let's think about that. Maybe it's a service as a shared service. It's a function. So think about infrastructure and how you manage all the process independent of the application, and say how you're going to use the data. Sometimes that actually can be productive to outsource if you think about it that way. So it's like what you own is your own workflow and how you use the data, but sometimes there's layers below this that's more commodity-ish that you don't necessarily have the wherewithal to do as an organization if your core mission is patient care, not infrastructure and how the integration works. Is that, if you think about it that way?
I would, with full admission that I'm very biased when I speak about this. My observation is that a lot of organizations, if not most healthcare organizations, tend to view it more on the like 90% commodity, 10% institutional, strategic value add knowledge work.
You need to flip that.
Whereas I think that it should be. It needs to be a lot more.
And
the number of I know Epic really well. The number of organizations that I've encountered that use Epic's capabilities to its maximum capacity is far in the exception rather than the rule. Most Epic organizations that I see that implement Epic put out like relatively boilerplate, and a lot of the executive decision makers view it as, well, we put in Epic, it should just work. They don't understand that, it's like saying, hey, use Excel and use it to analyze your data. And if you look at the vast majority of people who use Excel, they use it basically to just create a matrix that they copy paste into a Word document. They don't know that you can do actually some pretty hardcore data work within Excel. And I would the number of people that I know that use Excel that I've introduced into the concept of pivot tables is kind of shocking to me, actually.
Right. Well, John, there's a great classic Monty Python bit is, how do you play the flute? Well, you blow on one end and you move your fingers up and down on the outside, right? It's sort of the same idea.
Exactly. That's a great metaphor.
These things are really, really hard to do. But yeah, all I was just trying to say is that the organization, say your captive resources, tend to be very multi-hat, and a lot of times burdening captive resources with some of the basics is not necessarily the highest and best use of their time, and they tend to maybe go in that direction. So a lot of times it's kind of getting the mix right, say captive versus contract, because when you're talking about outsource, you're really just talking about, they're part of the organization, they're part of the team, they're just a different, relationship, the captive versus contract. So I think there's, I know you talk to a lot of organizations, so you've probably seen examples of what I'm talking about. I totally agree with you that there are times if you just outsource it as if it's just going to go away and it's just going to magically work. That's what you're trying to avoid.
Right. So let me use a very simple example on this. So oftentimes as physicians, we order stuff and the organization may say, well, you're ordering this inappropriately. So what we're going to do is we're going to put a hard stop and ask you why you're ordering something. And then they feel that that's going to solve the problem. Number one, a lot of times, and this goes back to some of the workflow things that I talked about, people will just click on something to get out of it. And it won't actually accomplish the goal that you want it to accomplish. Number two, you're going to create just really, really bad data. And number three, what people don't understand, like for instance, in Epic, if you do something like that, let's say you put a button as a hard stop within an ordering workflow of a particular test, there are actually mechanisms to actually pre-populate that based on data that's in the system. But I would venture to say that at least 80, probably 90% of Epic organizations don't even use that tool.
Right.
Because it goes beyond kind of a superficial level of understanding of the system. Going back to what I talked about with the 90 and the 10, it's just something that you put into place versus there's an opportunity to use the system in a much more elegant fashion so that, number one, you've made the system easier for the end user to use, and number two, then you create better data, and out of that synergy, you come up with, it becomes a virtuous cycle that kind of feeds on itself.
Yeah, and you had mentioned that before, that you had some success with it. So I guess, how did you close the loop on that? Did you get a chance to give that feedback to the organization, sort of celebrate that as a win, and maybe use that, as you said, to create the virtuous cycle? Or how did that look like when you had that?
Yes, there is some of that. A lot of it is also a little bit of build it and they will come. There is some leap of faith work that you have to do. But then, to your point, you have to get the wins to allow them to give you the rope to then take that leap of faith.
Yeah,
that's a mixed metaphor, but I think you get what I'm talking about.
Right.
Hey, John, just out of curiosity, because I know you're an expert on Epic, are they embracing the design of the EHR? Does it to actually enhance data governance? Is that a hot topic for Epic? And are they manifesting this at the annual users conference?
Yes and no. There are some basic structures in place, and I think there is some conversation around that. But my personal opinion is that there are some basic tools that have not been fully exploited, and that there's a substantial opportunity to use some of these tools that Epic has available that most organizations have not availed themselves of.
Can you highlight at least a couple of them?
Two of my favorite are some of the registry framework that Epic has, and also a data structure that they term smart data elements. Basically, it's a way to attach discrete data to things that are not discrete. And I'm working on a couple projects right now where I'm doing exactly that, where I'm attaching discrete data to free text documentation, and because that discrete data is now attached to the free text documentation, we can track that utilization of that particular tool, and then use that then to connect with certain output and outcomes.
Maybe if you could just translate that in layman's terms, get something that's concrete to get our heads around.
All right, so let me take a look. Take the example of that particular project that I'm working on. There is a mandate that we have in the state of Illinois that if we give a patient psychotropic medications to basically control their behavior, they're psychotic or they're drunk and uncontrollable, and they're a risk to themselves, we can essentially give them involuntary medication to address their behavior, to keep both the patient and the staff safe. When we do that, we have to document in the system using certain phrases and certain verbiage to say this is why we gave this medication. The classic approach to that is just kind of berate people and say, make sure you type this, or dictate, or put this documentation into the record, and then hope that when the auditors come, that they see that verbiage in the record. What I've done is we've directed people to use a certain type of tool within Epic. I've attached discrete data behind that tool. So now we can see, patient received this sort of antipsychotic sedative medication. Did the nurse document their documentation because there's discrete data attached to it? Did the physician use their version of that discrete data? And now it's in the record. Now we can actually track of the 100 times that we administer these medications, the nurses documented appropriately 50 of those 100 times, and doctors documented 40 of those times. And of the people who are the scofflaws, the outliers, now we know that it's these 3 nurses and these 4 doctors, rather than just going into the department meeting and just kind of browbeating people and say, make sure you use the term. Now we can actually focus our attention on the people that need to, where we need to focus attention on.
All right, I have one last question for today. Other than data governance, what are some of the other key issues that affect the success or failure of a healthcare technology project?
Well, I've talked about some of them already: usability, data governance, and coming up with the right insights. But that's sort of within a project flow. But I think 2 bigger issues are, at a more macro level, are interoperability. And I think I connected this, discussed this a little bit when I was talking about the population health platform or the ICU artificial intelligence platform, where it was displayed on a monitor. If it's not interoperable and you can't connect the pieces of the virtuous cycle without any special effort, then you're probably going to fail, or it's going to be very difficult. You've just made it more difficult for you to succeed. So interoperability is a huge issue. And quite frankly, I think that's why Epic has been so successful at what they're doing, because all of their tools work seamlessly with each other. As opposed to, say, CERN or Oracle, which has a lot of the same suites of tools, but they've absorbed those tools within their ecosystem by purchasing them, and the technology may be very different. They may have a certain tool, but they don't necessarily talk to each other. So interoperability is a huge issue. And then, of course, the biggest macro issue is the payment model and incentives. I was just, if you're not familiar with it, there's a neurosurgeon whose video has become kind of gone viral because basically he gave up being a neurosurgeon because he realized that the things that he was incentivized to do, basically, especially spine surgery, he realized that the surgery didn't necessarily help the patients. The things that helped the patients were things like exercise, diet, and other things that he could not get reimbursed from, and certainly his organization wouldn't get reimbursed for. So he had just this massive issue with cognitive dissonance, and so basically he quit. And so where I'm getting at with that is that the macro system is incentivized to collect data on things like the CPT code that you drop for a spine surgery. But I would challenge any healthcare organization that is taking care of, say, back patients. Are you discreetly actually collecting data on exercise patterns? Are you discreetly collecting data on what are their dietary patterns? And on a more granular level, what are they eating? Is it more vegetarian, or is it more meat, or whatever, or on the exercise, how far are you walking? Can you play with your grandchildren? Are you doing strength exercises? Are you doing flexibility exercise? I can guarantee you that nobody's collecting that sort of data, and certainly not discreetly. It may be captured in some sort of conversation or a note in free text, but it's hidden, and it would be a needle in a haystack to try to pull that sort of data out and actually come up with any sort of insights.
Hey, John, thanks for your insights today. It's been a great topic. So today you provide some great insights about illuminating the path to unlocking EHR data through data governance and innovative analytics. You provided some effective strategies to enhance care and drive operational efficiency. And you discussed how healthcare organizations can turn data into strategic assets required to achieve healthcare excellence. For those of you not aware, Spyglass is a product and go-to-market advisory firm focused on disruptive technologies and growth opportunities within the healthcare and life sciences industries. We have more than 250 satisfied customers who are technology companies, management consulting firms, and healthcare providers. And we've published more than 30 market research reports on a diverse set of informatics-related topics. To explore Spyglass's extensive library of paid research and to gain deeper insights into how technology is reshaping healthcare, I encourage you to visit my website at www.spyglass-consulting.com. Well, John, I'd like to thank you for sharing your time, insights, and perspectives. I also want to thank our sponsors, Storage Systems and Simplify Medical, who made this conversation possible. John, would you like to provide our audience with some closing remarks?
I think the solution to our healthcare problems is both really simple and really complex. The simple part is we just need to deliver information. The problem is that delivering the right information to the right people at the right time is exceedingly more complex than people think it is. And as you make your decisions on what sort of technology to use to solve these problems, don't underestimate the granular pieces where you may fall short.
Great, thank you, John. Keith, would you like to share any final thoughts on today's webinar?
Yeah, sure. So, John, I really appreciate part of the Beyond the Blueprint format is to give thought leaders a real opportunity to express, their successes and the challenges and the obstacles. So, I mean, this is an amazing, very articulate, very clear vision that you've laid out for us and the challenge that's ahead. So, I really, really appreciate that. I think one of the things we kick around at Beyond the Blueprint is the idea of we should at some point host a summit, like have you and 30 of your other colleagues that are facing the same challenge. We get together and continue to work these things out because it's, as you said, there's part of it that's really simple. There's part of it that's really, really complicated. I'd love to, you to keep working with us on this journey if that sounds interesting.
Oh, absolutely. I'd be happy to participate.
Great. Thanks, Keith. Thanks, John. Well, at Beyond the Blueprint, we look forward to continuing our conversation with you in future episodes of the series. And John, we'll definitely be looking to invite you back for another informative discussion. Until then, thank you very much.
Thanks, everyone.
Thank you for having me.